All right, let's jump right into today's explainer. We're tackling a genuinely critical topic, transforming the NQIS fire safety standards into an actual workable checklist to protect vulnerable patients. We're going to take all that complex regulatory text and boil it down to the exact steps your facility needs to be safe, compliant, and totally ready.
So, let's kick things off with a high-stakes question. Picture this. A fire starts right now. Who leaves first? Because in a healthcare facility filled with immunocompromised or non-ambulatory patients, well, seconds count, and every single decision matters. You absolutely cannot be figuring out your evacuation hierarchy while smoke is literally filling a corridor. You need a plan. The National Quality Assurance Standards, or NQAS framework we're looking at today outlines strict, life-saving compliance rules for your facility. Now, primary healthcare centers might not always have massive multi-story infrastructure, but the NQAS mandate remains crystal clear. You have to have explicit fire preparedness measures in place before any quality certification can even begin. To make this easy, we've broken this down into a 5-part actionable blueprint. 1. Equipment maintenance and audits. 2. Staff roles and responsibilities. 3. Sensitization meetings and drills. 4. Patient evacuation priority levels. And 5. Non-ambulatory patient evacuation. Starting right off with Section 1, Equipment Maintenance and Audits, the foundation. The documentation required for your monthly fire extinguisher audit is pretty extensive. It's not just about glancing at a cylinder as you walk down the hallway. It's a formal checklist ensuring nothing slips through the cracks. You gotta log the total number installed, explicitly say whether each one passed inspection, flag any that failed, and crucially, get a signature confirming the medical officer in charge is notified. That right there creates a direct chain of accountability. And here's the kicker for anyone doing these monthly checks. Verify the pressure gauge. The needle must always be in the green zone. If that needle hits red or if it's dropped completely to the left or right, that extinguisher is essentially useless. It's going to fail you during an emergency. Fire doesn't exactly give you a timeout to go find a replacement, which is why getting this monthly check right is so vital. Okay, moving on to Section 2, Staff roles and responsibilities, the human element. Once your equipment is sorted, you have to secure the team. Every single facility must form a rapid response team, or RRT. Now, this isn't just an informal group of people who happen to be around. It's a designated first responders team. It needs a chairperson, usually the facility in charge, and proactive staff members like nurses, lab techs, and security staff. They're your leaders in an emergency. The guidelines actually recommend keeping this exact team configuration for at least 3 months to really sustain their training. But your RRT isn't just there to put out fires. They have a massive operational checklist. Yes, they respond immediately and raise alarms, but they also conduct regular facility inspections for hazards, like, say, loose wiring. They train the broader staff, lead the mock drills, and, this is huge, perform a gap analysis after every single drill to fix what went wrong. Which brings us nicely to Section 3, Sensitization meetings and drills. Practice makes perfect. Having a great first responder team is awesome, but it's not enough if the rest of the staff just panic. That's why you need rigorous sensitization meetings and mandatory quarterly drills. During these meetings, you have to cover a specific curriculum. You're teaching basic fire prevention, exactly what to do when an alarm sounds, and how to shut down non-essential equipment. That's especially important for oxygen supplies, which, as we know, can feed a fire. You also need to outline everyone's specific role in helping vulnerable folks, like neonates and geriatric patients, escape safely. Now, to make sure the staff actually remember what to do during the sheer panic of a real fire, the NQAS framework pushes the RACE protocol. Step 1 is rescue, get anyone in immediate danger out. Step 2 is alarm, hit that manual call point and shout for help. Step 3 is confine, close the doors to block the smoke, and finally, Step 4 is extinguish, but only if the fire is small and it's actually safe to do so. And when it's time to actually use that extinguisher, staff need the PASS mnemonic. Pull the pin, aim at the base of the fire, not the flames, the base. Squeeze the handle, and sweep side to side. Oh, and it's also worth noting from our sources that you should be standing at a safe distance of about 2 to 2.5 meters away when you do this. Speaking of numbers, here's one you really need to take away. 2.5 to 3. That is the target time in minutes to completely evacuate the building during a mock drill. In the source training materials, evaluators pointed out that drills often drag on for 5 to 7 minutes because staff just don't take it seriously. They kind of casually walk out.
2.5 minutes? That requires urgency, seriousness, and knowing exactly where you're going.
All right, Section 4, Patient Evacuation Priority Levels, Triage in a Crisis.
This takes us right back to our opening question. If you literally only have 3 minutes to clear the building, how do you logically decide who gets out first? Well, here is the triage model. Level 1, those closest to the hazard in immediate danger. Level 2, ambulatory patients, folks who can walk out quickly on their own. Level 3, patients in general wards who need transport assistance, like a wheelchair. And finally, Level 4, patients in procedural units, like the labor room. They go last because they require the most time to package up and are logistically the most complex to safely move. And that leads us to our final part, Section 5, non-ambulatory patient evacuation, the climax of the rescue.
Let's tackle the toughest part of this explainer, safely evacuating those non-ambulatory patients who physically cannot move themselves. Now, there is a stark difference between a standard evacuation and a life-threatening one. In a standard evac, non-ambulatory patients are just advised to head to the assembly point escorted by their normal attendant. But in a life-threatening scenario, where the fire is advancing, the rapid response team has to completely take over. They step in to forcefully but safely evacuate that patient.
To pull this off, the RRT relies on specific tools. They're going to use wheelchairs for minor casualties or partially mobile patients to just get them out fast. For major casualties that need full physical support, they use stretchers. And meanwhile, the facility's medical and first aid teams, they must be standing by at the designated outdoor assembly point. They do not run into the fire. They wait in the safe zone to immediately triage and treat these rescues the second the RRT brings them out. So, we've covered the strict documentation of equipment, the specific roles of the RRT, staff sensitization, and the really heavy choices of patient rescue. And that leaves us with one final critical thought about your own facility's readiness. Ask yourself, are you currently relying on luck, just hoping a fire never happens? Or is your team actually prepared to execute this exact NQAS blueprint today? Take this checklist, implement these protocols, and make sure every second counts. Thanks for joining me on this explainer.